So in any case, we will send you mails, we'll put it up at the appropriate sites, and you will get an email from the IAP regarding the exact timings, but the link will be same. If it is changed, we'll inform you accordingly. Should we begin, Rajesh?
Thursday there won't be.
So next Thursday there will be a clinic here at Sion, but it won't be broadcast. It will be broadcast on Friday from Delhi, Lady Harding Medical College at 4:30 p.m. Ready? Dr. Ramya, come.
Good evening, everyone. My patient Ayush Gupta, 1 year 10-month-old male child, first by birth order, born of non-consanguineous marriage, residing at Ghatkopar, hailing from UP, Gupta by community, Hindu by religion, brought by aunt with chief complaint of delayed attainment of milestones since birth and fever and convulsions 3 months back. History goes back to 3 months back when child developed fever which was moderate to high grade, not associated with chills, intermittent in nature, responding to medications without any diurnal variation. On third day of fever, child had paroxysmal event in form of tonic posturing of left upper limb and lower limb along with staring look which lasted only for a few seconds, not associated with frothing around the mouth, not associated with bowel or bladder involvement, and there was no any postictal drowsiness. 4 to 6 such episodes occurred in a day, and every time it was not associated with fever. For the above complaints, child was taken to a local doctor at UP and was prescribed some medication and was told that it was an anti-epileptic, and following that medications even this paroxysmal event subsided. Child was also not admitted during the same time. After 15 days, parents stopped the medication on their own without any consultation. After 1 week of stopping the medication, child again had similar paroxysmal episodes which were 8 to 10 per day this time. This lasted around 8 to 10 days, similar semiology, following which child was again put back on medications. Since past 1 month there is no repeat such episode, and the second time there was no associated fever. Throughout the course of illness there is no history of altered consciousness, no history suggestive of any focal neurological deficit, no history suggestive of any cranial nerve involvement, no bowel or bladder involvement. There is no history of aura, no history of fever with rash, no history of trauma, no history of Cox or Cox contact, no history of jaundice in the neonatal period, no history of vomiting or irritability, no history of similar complaints in the family, no history of otorrhea, no history of constipation. Birth history: mother was antenatally registered at 3rd month and she was immunized with 2 doses of tetanus toxoid. She received iron, folic acid and calcium supplements for 3 months. Ultrasonography was done at 7 months of gestation. There is no history of fever with rash, no history of any ingestion of drugs or radiation exposure, no history of diabetes or hypertension or any other medical illness in the mother. It was a full-term normal vaginal delivery at hospital. Baby cried immediately after birth. Birth weight was 3.2 kgs. There is no NICU stay, no history of any neonatal jaundice, no history of child being sick in the post-neonatal period. Child was started on breastfeeding within 1 hour of life. Developmental history: gross motor, child attained head control at 6 months of age, rollover at 7 months. Child started to sit with support at 1 year, sitting without support at 1.5 years. At present, child can stand and walk with support. DQ gross motor wise it is 54%. Fine motor, opening the hand at 3 months, palmar grasp at 1 year, takes feet to mouth at 1.5 years. Developmental quotient is 27%. Language, cooing at 6 months. At present, child can only babble. Developmental quotient is 22%. Social smile at 6 months. Other than that, child doesn't know anything. Child can see the objects. Child cannot hear. There is no startle response also. Immunization history: booster. Child is immunized till measles vaccine. Booster 1 is pending as per universal immunization program. Diet history: child was exclusively breastfed for 4 months. Thereon started on bottle feeding. At present, child consumes rice, dal, biscuits and cow's milk. It's deficient in calories by 300 kilocalories and proteins by 2 grams. Family history, they belong to lower socio-economic status as per modified Kupuswamy classification.
You were a bit too fast for me, so we'll go back to some things. So you said fever and seizures last 3 months, or 3 months back, right? So in the first description there was some confusion. You said fever for 2 days and on the third day first paroxysmal event, and then you said not associated with fever. I was a little confused.
Sir, on the third day of illness, there were 4 to 6 episodes. Everything, all the episodes occurred on the same day, with a gap between each event was around 1 to 2 hours. Like throughout the day, there was no fever. Once or twice when there were convulsions, there was fever. Rest of the time, there was no fever.
But what about after that?
After that, fever also subsided, convulsions also subsided.
So what you are trying to say is that a febrile illness started, and on the third day of the febrile illness, the fever was kind of subsiding, and on that day there were 4 to 6 events.
Yes, sir.
That's what you are trying
Yes.
to say. Okay. Now, if you all got that history, what do you want to respond to that? What is this event that you think of? What was happening? What are your thoughts? So this is a 1 year, 7-month-old child at that point, right?
Yes, sir.
Today 1 year, 10 months. So 3 months back, 1 year, 7 months. Yes? Anybody would like to speak? What do you think it is? Yes?
Sir, in the history, one of the complaints was developmental delay since birth, and as it was evident in the developmental history subsequently, so I feel that first there might be underlying developmental delay disorder, and superimposed on that is this intercurrent illness, what in the form which has manifested in the form of fever and seizures, because the semiology of the fever and the seizure go hand in hand. The seizure subsides along with the fever, and this is an intercurrent illness, and in the background of probably a developmental delay disorder, or like a global developmental delay disorder.
No, agree. So I agree that there is a background of developmental delay disorder. What I am trying to say is, how will we analyze this fever with these so-called seizures?
Sir,
Then we will correlate the developmental delay.
the age of the child, 1 year, 10 months, most probably febrile convulsions which could be precipitated.
Come. So now your comment on calling this a febrile convulsion, and then further on whether simple, complex, etc. So would you call this a febrile seizure?
Could you please repeat the semiology of the seizure again?
There was posturing of the left upper limb and lower limb, followed by staring look, which lasted for 5 to 10 seconds.
And single episode in 24 hours?
No, 4 to 6 episodes in 24 hours.
And I would call it as a atypical, a complex febrile seizure.
Okay. So what are the features which are atypical?
One is this focal involvement.
So one is focal.
And then the number of episodes in a period of 24 hours.
Number of episodes are more. Onset on day 3 of the febrile illness is more.
Yes.
Is odd. What else? Anybody? What about you? Any other atypical features? Speak in the mic. Anyone who wants to speak will raise hands. Mic will be brought to you.
Recur again in 1 month. So multiple episodes in a day.
Yeah, which he already said. What is your comment on the first time child getting seizure, which we call as febrile seizure, at the age of 1 year 7 months? So those who get febrile seizures typically, what is the age at which they get it? So though the age of febrile seizures in books is 6 months to 3 years or 5 years or whatever, but the first episode is usually pretty early in a child who is going to get it. So the later the first episode occurs, the more wary we are of the future. Means this may not be just a simple febrile seizure. And then of course the developmental delay which he said. So this is not a developmentally normal child, right? So these are all the multiple atypical features or so-called risk factors. Okay, I think
we should be very clear that what is a febrile seizure? It is not something where a seizure and fever go together. Acute bacterial meningitis is not a febrile seizure, but there is fever and there is seizure. So when we are talking about febrile seizure, we mean that it's the fever that causes seizure, and not any kind of fever with any kind of seizure. So let's not make a mistake that febrile seizure, typical, atypical, whatever, is a fever-induced seizure. Whether the bacterial meningitis, viral encephalitis, whatever, several other causes of seizure may also have an accompanying fever. For example, a fever triggered URTI with a hypocalcemic seizure is not a febrile seizure. It's a fever-induced hypocalcemic seizure. So make clear distinction. A febrile seizure comes in only if in a normal brain within first 24 hours there is an onset of seizure. Then you go further and say typical, atypical, etc. So to begin with, this is not a febrile seizure. It is a fever and seizure. Two things are different. Okay. So make that very clear, and therefore this is anything but a febrile seizure. Then what is the cause of seizure? When the fever goes down, almost and the seizure comes. That is what you need to discuss. Why did the fever disappear and a seizure came? Is it an intracranial infection? If not, then what is it? What makes the fever disappear and a seizure come up? That's the first thing that you should now discuss. Who will take this and say, what is the reason why the fever disappears and a seizure comes? Any thoughts on that?
Normally we know that the seizure should occur in a febrile seizure at the peak of fever. That means the fever is high. So what is the explanation? What is the relation of fever and a seizure?
I think there is no relation between the peak of fever and seizure. There any time of a fever, and should be within 24 hours, not relation with the height of fever.
If a child has fevers quickly rising to 103, 104, and after cooling measures are given, the temperature comes to 9900, is he expected to get a seizure at that time, or he should have got it earlier? Normally he would get it much earlier. In fact, the rapid rise of fever is what often precipitates the seizure. Okay, so unless you entertain something like that, the fever was down was a misnomer and the child did have high fever because nobody saw the rectal temperature and the body had become cool for whatever reason and the fever was still high. A truly subsiding fever, normally you would expect the seizure to have come much earlier than that. So here fever may be acting as only a triggering factor for which there may be other associated or some other etiology. Also, one close differential diagnosis of a febrile seizure is give a typical history. A child of 12.5 years had a very high fever and he was vomiting twice, after which he developed a seizure. It looked like a simple febrile seizure. 12 hours later he vomited once and he had two very large, watery, foul-smelling motions. After which he started getting multiple small mucoid motions. What am I describing? Shigella encephalopathy. That may mimic febrile seizures very closely. And the prognosis in both is different. Lot of Shigella is going on just now also. So Shigella encephalopathy in the first episode is going to be rather close differential diagnosis. What sir was also trying to say is that the cause of fever is extracranial in febrile conversion is a part of definition, and a very valid point, the age of fever. And also, not only the later ages, but actually earlier age is more typical. Perhaps we would accept a 2.5-year-old child getting a febrile seizure for the first time, but accepting a 4.5 months, 4.5 months child with first febrile seizure perhaps makes it little more typical than a later age. So age is very important, later and earlier, perhaps earlier more than later.
So to put that relationship of fever and febrile seizure in context, what Khare sir was saying, peak of fever, it's a complex or a heterogeneous group. So while many children do get it at the peak of fever, but it is not necessary or compulsory that you must get it. There are many others who don't get it with high fever, they get it even with low fever. So what here he mentioned that height of fever is not necessarily correlated with the seizure. So coming back to our case, so we have clearly decided that we will not call this a febrile seizure because of what Amdekar sir said. Now his question was what is this situation? So one is that this was a child who was prone to, let's say, epilepsy or seizures, and the fever served as a trigger. So fever was an intercurrent illness. Any other situation where fever disappears or goes and seizure comes up? Maybe not in this child.
So just tell me, forget the seizure. Any complication that occurs soon after fever disappears. What is that due to? Somebody may start vomiting, fever has disappeared. Somebody gets a severe abdominal pain, but fever has disappeared. Somebody gets a seizure when the fever has disappeared. So what is common pathogenesis when the fever disappears but the new complications come? If you know that, then you know the answer to this seizure also. You all have seen such patients. Okay. Fever disappears, the complication comes. Why should fever disappear and a complication comes? Haven't you seen a dengue doing that? Fever disappears and the complications come. Why?
It is just immune mediated response to the infection which really goes down and again the complications occur.
Very good. So one way a fever disappears but triggers an immune response and any complication can occur. Can there be any other pathogenesis where a fever disappears and a complications come up?
Disseminations, infection when spreading to the other system when disseminated, that might be fever subside and other complications occur.
When the infection spreads, fever rarely disappears. So fever won't disappear. Okay. The only other way is a metabolic disorder. Okay. Metabolic disorders may follow a fever going down, it's triggered and a metabolic disorder comes up. So can this be an immune mediated or a metabolic disorder? We first said it's not a febrile seizure. Next we would say this is not an intracranial infection, common bacterial or viral. But tuberculosis is an immune mediated disease. Can this be a TBM coming up? So give a thought to that. Could it be a cerebral malaria doing that? It's a complication of fever. Fever goes down, may come up again. So is it cerebral malaria? Is it TB meningitis? Let's look at that first. Then look at what else is there. So can somebody throw light on what I've asked?
For the malaria, it is a high grade. It should be high grade fever with erratic. It is like interfebrile childish fever. There was no such a high grade spike, so it is very less likely for malaria.
So one is the fever should not have disappeared. Second point against malaria.
The high grade fever spike.
High grade okay, but what else?
Yes. Other complications is also there,
like
renal complications, hypoglycemia, and
okay, but CNS wise, why you altered sensoriums? So you expect that cerebral malaria who is going to throw up a seizure is also going to have altered sensorium. Same is true for meningitis, which, sir. What about TBM? Can this be TBM? Not today. You have to think backwards as if you were on day 3, day 4 of this illness, and on that day would you have thought of TBM?
Rajesh, there are some questions related to febrile seizure. Can I ask them now? So, the message says, sorry to disagree, sir, but books mention that child's background neurological status is not taken into account to say if it is a febrile or a non-febrile seizure. Your comments on that? Sir said that a normal brain is which is the one which is triggered by the febrile seizure. He's saying the previous neurological status is not taken into account.
Yeah, I think what we are trying to say, what sir is trying to say is that when we have an understanding of febrile seizure, we are talking of a child who doesn't have anything else, and we are dividing this febrile seizure into simple and complex, and when we are dividing it into complex, we are trying to estimate future risk of epilepsy. Besides that, there is nothing else involved here. That's the category of febrile seizure that we are thinking in our mind when we talk of febrile seizure. Whereas what sir is trying to tell us is that whenever there is this kind of a situation, like a developmentally abnormal child, or the sir gave the example of meningitis, that febrile seizure is just those two events occurring together. That's not the important thing at all. What is important is the other part of the illness, the meningitis, or now here the developmental delay and this child getting seizures. So what I feel is it's a conceptual thing that sir is teaching us, that for a concept, remember that febrile seizure doesn't have any of those other things involved, right sir?
Yeah, if a child who has a previous background of a neurological disease, say a delayed development, and such a child gets seemingly typical febrile convulsion at the age of 1.5 years and has come to me relatively in a quiescent stage, though at that moment the diagnosis may be a febrile seizure, I will have a few things at the back of my mind. And I would most importantly think that this is seemingly a febrile seizure occurring in a developmentally not a normal child, and therefore chances of this particular child getting recurrent afebrile seizure or substitutive seizures are higher. And therefore, even if I write diagnosis simple febrile seizure to be followed for further afebrile or febrile seizures and development.
So just a point, when a child's background, is developmentally not normal, we would not call it a simple febrile seizure, it would be a typical febrile.
I think the whole reason calling febrile seizure has a clear concept. Don't worry, this child does not need much follow-up. Okay, well, he may get another seizure with another high fever, but he will not have any brain dysfunction. He will not have any high risk of epilepsy. He does not need EEG. He does not need imaging. He has to be certified as a normal brain person. That is febrile seizure. Okay, so it's not just, it's a label we are talking about. But when you are talking about a fever-induced seizure in first 24 hours, typical, but in a brain dysfunction child, you are calling for further follow-up. You are expecting some deranged brain function. You are expecting probably an EEG. You are expecting a future seizure. You are expecting a long-term treatment for epilepsy. That is the connotation. So I think we are very clear about this, that a febrile seizure leaves behind nothing wrong in the brain, whereas any child who is already deranged in the brain and gets a febrile seizure should not be called a febrile seizure. And I think that part is very clear. Yeah? So my question to you was that, first convince me it's not an intracranial infection. Then go ahead. Intracranial infection can occur even in a child who is already delayed development. Okay, he's still likely to get. So first rule that out. Okay, to make it simple, let's call recurrent seizures as an epilepsy. And this child therefore answer one question: is it acute symptomatic epilepsy or is it a remote epilepsy? Okay, it's not an idiopathic epilepsy, obviously. Is it acute symptomatic, which means just now there is an acute insult to the brain, or is it a remote epilepsy? who will take this question. If you take this correctly, then you know what you are talking about. Remote is already some problem exists. Acute is maybe acute on some problem, but who will take it? I suppose you will have something to say. Come.
So first sir is asking, explain acute symptomatic seizure and remote symptomatic seizure. What are these terms? Explain that.
Acute symptom.
Anybody else?
So acute symptomatic seizure is there is some acute insult, maybe some CNS infection, maybe trauma, maybe raised intracranial pressure due to some cause, and there is a manifestation of seizure. And so remote symptomatic means there is already insult has occurred maybe in the newborn period, and the manifestations we see in later on like hypoglycemia. As this child has developmental delay, there may be the chances of remote symptomatic seizures are on higher side.
Okay, so that's acute symptomatic and remote symptomatic. Okay. What about sir's question, whether on that day, on the 4th day, would you have thought of intracranial infection?
So child was not sick otherwise, so that is less likely. But on 3rd day with fever and convulsion, that has to be kept in mind. Later on child...
Yes, so how will you weigh for or against? Will you do a CSF on that day to rule out intracranial infection? So that's what we are asking.
if the child was not at all sick and actually...
Elaborate on that, not sick. What do you mean? You're right, but can you elaborate on that?
In between convulsions, child was doing routinely as he was otherwise, and there was no post-fetal drowsiness.
Doing routinely means doing what? Accepting feeds, very, very good.
No vomiting.
Child is not lethargic, accepting feed well. After taking feed, sleeps normal.
No irritability and vomiting.
Yeah. So there was no change in sensorium and behavior of the child. Whatever the child was capable of doing at that point, the child was doing on that day also, between those episodes of seizure as well. And there was no sign of raised ICP in the form of vomiting, irritability. So for all these reasons, you would have thought the possibility of intracranial infection to be low down.
All that you would have said is that there was no symptoms or sign of encephalopathy. That sums up everything. That means that the brain function was very clear to whatever extent his development allowed. So every infection, like a TBM, he throws up a seizure may disappear, fever also may disappear. After all, in TB, fever is off and on. So there could be an off period the day you saw. That doesn't mean that there is no infection, but a child with a TBM who throws up a seizure has an encephalopathy. And what is encephalopathy? Change in behavior. So, after all, the brain cell is not functioning totally normally. In this child, if you convince us that he was alright, that's what you said, in between seizure, he was alright to whatever extent his brain had developed. But he did not have drowsiness, he did not have behavior disturbance. Okay. So, if there is no encephalopathy, that means it's an isolated electrical discharge. That is what is called as an epilepsy.
I have one doubt, sir. So in a child who is developmentally delayed, who is already in a different, who is not oriented to time, person, place, so then how do we judge encephalopathy in such a patient?
Encephalopathy is a change in the sensorium, for example. A delayed development child is in full senses. He does not understand something appropriate for a child. For example, when you will see this child, you will be able to say, oh, he's conscious, he's maybe responding to surroundings. That is what is encephalopathy. Whereas he may not understand what is happening in his surroundings. That is not an encephalopathy. You are clear about that.
This particular awareness of that is because of the adult neurology, conscious, cooperative, all that. Now in a child, what you are going to see is how is he responding to surroundings as usual. He may not recognize you as or somebody as that, but his response, his looking at it has been unaltered as compared to what it was earlier. He may be smiling, he may be still not very comfortable going to the strangers. All those things are the same.
That is how in this child now you would say that he has an acute onset of an epilepsy which looks like a remote epilepsy and not an acute symptomatic epilepsy, because he had no encephalopathy, there is no intracranial insult, and because there is no evidence of any active disease in the brain, and he has got a past history of a delayed development, we could call it a remote. And now at this point of time, we must discuss why he is delayed. Okay. So now the next issue comes. With seizure we are okay. Seizure is a part of his damaged brain. Now why is the brain damaged?
Sir, why can it not be an inborn error of metabolism?
I think the inborn error of metabolism does not present just as a delayed development, especially if it is static. It's a progression. Most of the inborn error of development come up with, say, acute onset of vomiting, failure to thrive, seizures, and most important, progressive disorder. So that totally rules this out, and therefore we have no reason to consider inborn error of metabolism.
Yeah, so what do you think is the cause of this delayed development? First we'll talk of big groups and then we'll try to narrow down if possible.
Infection, metabolic,
Even first, can we do little bigger groups?
Natal, prenatal or postnatal?
Very good. So first you decide whether in this child it is prenatal, perinatal or postnatal. So what do you think?
So less likely it's a natal. Perinatal history is uneventful. As the history says, like baby cried immediately at birth, it was birth weight also adequate.
Okay.
So it is less likely a perinatal history. It is most likely prenatal, maybe a cause for this.
Okay, one sec. So baby cried immediately after birth is equal to no perinatal problem, and baby did not cry immediately after birth is equal to perinatal problem. Is this statement correct? So how do you judge this?
Baby cried immediate after birth is equal to no problem, but did not cry immediate after birth. We should also see about the activity, colors, and respiration and this thing.
Yeah. So more than cried or not cried, the behavior of the baby on that first day or the first few hours is extremely important. So we have to establish what sir just described about the older child. Same in the newborn period. We have to establish a neonatal encephalopathy, present or not present, to decide whether there was any intranatal problem or no, perinatal problem or no. Okay. So in this case, she said that the baby was given to feed 1 hour after delivery and the baby fed well. So that tells us that the behavior of the baby was normal, so no perinatal issues. So prenatal or postnatal. Why not postnatal? I'm sure it's not postnatal, but why not? You should answer that.
There is no history of any sepsis or meningitis in the child, no history of trauma.
And so there is no history of any illness in the postnatal period, and your delay, even your first milestones which you described in different categories were delayed, the first appreciable milestone. So the problem has started right from beginning, so that's why not postnatal, plus of course no major illness.
Why not a hidden postnatal? Okay, you cannot get away saying there is no postnatal. You say that not manifest postnatal. That means there is no meningitis, okay. He didn't have a seizure of an acute onset. But he could have had a hidden insult postnatally. Name one most common.
Hypoglycemia, but 3.2 kg is less likely to IUCR.
So now we want to know what was his birth weight. Okay, Was he a susceptible child for hypoglycemia? And can a full-term normal baby also get hypoglycemia? Yes, it could. Therefore, don't forget a hidden postnatal fact. Okay, there was no obvious meningitis test. Also ask whether there was any intervention at birth. Many times, it was a difficult delivery, so the doctor gave 3 days some amoxicillin. So that could be just good enough to fire off a bacterial infection and become chronic. So get all those histories on that. Then what about, you said no prenatal. Okay, how can you say no prenatal?
Prenatal can be there. Any metabolic like disorder and this kind.
So which prenatal? In prenatal now you have other categories. So what do you think is this? What are the categories that you will consider in prenatal?
Sir, antenatal infections like TORCH group,
Okay.
then metabolic. Two are the most common categories. Infectious looks less likely because there is a good birth weight of this baby, like 3.2 kg. Mother has no significant history in the antenatal period, like fever, rash, lymphadenopathy, or any admission. So antenatal infections should be kept in mind, but they are less likely. And metabolic can be there, metabolic category of disorders.
Okay. Anybody else wants to say anything? Any other considerations?
Congenital malformation of brain.
Okay, very good. Then what about chromosomal or genetic? Chromosomal defects. Okay, so that is also syndromic. So that is also prenatal, right? Okay.
Conventionally, it's good to divide the prenatal causes into genetic and non-genetic. In non-genetic causes, you have intracranial infections, intrauterine infections. Then you have accidental exposure to radiation, certain drugs that may have been given to the child. The importance is these causes are not likely to recur in subsequent pregnancies. And if there is a history of a few PCBs being affected, of course this category doesn't apply. Amongst the genetic, you have the chromosomal, then inborn errors of metabolism, then syndromes including the MPS. Hypothyroidism can also be considered as part of that. Then inborn errors of metabolism, protein, calorie, and protein, carbohydrate, then mineral metabolism, fat metabolism. In mineral metabolism, you have certain abnormalities of copper metabolism like manganese. So it is good to divide them into heritable and non-heritable. 4 causes of non-heritable and a few causes of heritable. So you're not likely to forget them. And of course, a number of syndromic causes, genetic.
Okay, now we'll come down to the developmental history and analyze that. So, have you heard the developmental history? Do you want to comment on that, or you want to go over it quickly again?
Gross motor, should I tell? Head control was attained at 6 months, rollover at 7 months, sit with support at 1 year, sitting without support at 1.5 years. At present, child can stand and walk with support. Developmental quotient is 54% gross motor.
Okay. So now when you look at this developmental quotient, what are you looking at really? What is the aim of finding out your developmental quotient?
Which of the domains is more affected and how much, whether it's profound or...
Okay, so one, you want to know severity of affection. Second, you want to know which domain is more affected. Third, what is the other purpose of this developmental quotient? Excellent. Static or progressive? How do you make that out?
Initially, the development is may be delayed, but up to a point normal for age. Thereafter, not achieve any development. So it's static, and progressive delay is delay.
No. Can we?
Static is like we need to calculate the developmental quotient 1 year back. What he had attained at 1 year, what was the developmental quotient? If that and this correlates,
Very
then
good.
it is static.
So do you think in this it is a steady progress, or do you think that there is a worsening? So you said 6 months was first milestone. You said was
Head controls.
head control at 6 months. So you wanted it roughly at 3 months. It's at 6 months. So 50%. Then
Sitting with support at 1 year.
okay.
Then standing and walking with support 1 year 8 months.
Yeah.
Around.
So it is more or less maintained. Okay. Now what about the other ones? Second field.
Having come up to that of 1.5 year, if there has been no progress in the development at all, till 1.5 year it looks static, but there has been no progress in the development at all, it may not be static, and it might mean a progressive disorder which is setting up today. So attained, and then there has been a plateau, and there is no further achievements in the milestone up to 1.5 years. Then again it's a warning that this may be slowly progressive disorder. Today the progress is not so very apparent, but already giving you some warning signs that this child should have achieved it.
Fine motor, child hand open at 3 months, palmar grasp at 1 month, he takes feet to mouth at 1.5.
Hand open at 3 months. See, now this palmar grasp. Now this is always a little bit of a confusion. Palmar grasp is a reflex and a examination. It is not a history. You should not ask on history these things, because the mother may not be able to notice such small fine things. Okay.
So holding for object or reaching
so
for.
holding means what you can ask the parent is that when you brought a rattle close to the baby, at what age did the baby attempt to go for the rattle, or when given a toy, when the baby hold the toy, that is what you ask. But you don't give this palmar grasp as part of history.
Reaching out for object is at 1 year.
Correct. So then how can palmar grasp means? Okay, go on. So reaching out at 1 year. So what does that mean? What is the DQ here? You want reaching out for objects at what age? Even earlier.
4 to 5 months.
4 months maybe. So
it's around 30. It's around 30.
30.
Even now it is.
Yeah, fine. Then
language cooing at 6 months. At present, child is babbling. Babbling started at around 1.5 months. Mother doesn't. She's not giving exactly from when child started to babble.
okay.
And social smile from 6 months of age. Other social history I couldn't elicit.
So what would you have asked for beyond the social smile?
Recognize the mother, stranger anxiety, then bye-bye way.
Okay, so stranger anxiety is
not there.
Okay, then
Recognize the mother,
Does not recognize.
and bye-bye wave.
okay. So do you find a disparity in that does not? When does a baby recognize the mother?
3 months around.
Yeah, so pretty early. So do you think that this baby is this field is that delayed that this baby is not able to recognize the mother, or you would think of some other reasons?
Local vision problems.
Yeah. So how do you know that the baby doesn't recognize the mother? Means recognition is not just visual recognition. Yeah? Yes?
Response to sound.
Yes. So with the mother's voice does the baby calm when the baby is crying, or with when the mother holds versus somebody else holds does the baby. So all this is also recognition of the mother, right?
Child is same with anyone, sir. Like she is the aunt, she is not the mother. Child is comfortable with her, like
No, that is lack of stranger anxiety, which is fine. What I'm trying to say is that judging that the baby cannot recognize the mother is difficult, one, and second, that would put the baby to be near, I would say, neonatal or day one types, which is, it is not easy to put that down, right? Okay. So now what is your assessment of all the fields? Do you have any pattern in that?
Language, social and fine motor are affected more than gross motor.
So,
and there is hearing impairment.
okay. How do you know that?
Mother is also telling, and in developmental assessment when I look for startle reflex, child is not having.
So is startle reflex a good way to assess hearing impairment? So startle reflex is a very crude way, and it will just, it's just telling you one point. But in such a big baby, 1 year, 10 months, you would expect the baby to localize sound. So you would expect the baby to look towards the voice of the mother calling from one ear.
But I thought absence has got a significance, and excessive startle also has a significance. Absence would definitely make you alert that there is something wrong, and excessive will point out towards many more conditions where you can have an excessive startle.
Yeah. So if the parents are sure that the baby has never startled, yes, it has a significance, right? Okay. Now, so what does this pattern tell you? That social, language and fine motor more delayed than gross motor. What does that tell you? So means can we just quickly revise three basically broad groups where this will give us a clue? Anybody? Yeah.
Sir, I feel that all the four domains are delayed. And I feel this is a global developmental delay, since the development quotient in two or more domains is less than 70%.
Absolutely.
So I think this is a more global developmental delay, and it is very, if as per the history, if what she's saying is, if the fine motor, social and language are more delayed than global, then probably our diagnosis, the etiological diagnosis, will go in a different direction. Probably she's hinting toward like a developmental dissociation where one domain is more delayed than the other.
Correct. So what I'm asking is, what is the significance of developmental dissociation? Does it give us some clues?
Yes, it gives us the etiology behind the development delay. For example, if there is a gross motor delay and rest of the domains are intact, then the etiology for that particular disease becomes different. Say it might be a myopathy or a neuropathy. But if fine motor, social and language all are delayed, that means we are dealing with probably something higher, like probably a probable brain damage or a cortical involvement, because other.
So essentially, when you have global delay, like you just said, but within the global delay, if your motor is much more delayed than your mental, social and language, you are essentially dealing with a movement disorder like CP. Whereas if all global delay, but in this kind of a situation where your social and language is more delayed than your motor, you are essentially dealing with a mental retardation category. And when you have only social and language delay and no motor in this delay, then you are possibly dealing with autistic spectrum disorder or learning disability or whatever, right? So, shall we get on to exon history? What's your final conclusion? Summary, 2-3 sentences.
It's a static epilepsy, remote symptomatic epilepsy.
Remote symptomatic epilepsy
with global developmental delay.
With global developmental delay, with dissociation in the form of more affection of social language than gross motor in a normal birth weight child, right? Probably of prenatal origin, right? Okay. Now let's examine the baby. Yeah.
The question is that DQ will change possibly when you do an examination and assessment. Is it appropriate to comment on DQ at this point of time, or should we comment on it when we have done the examination?
So, I mean, you're absolutely right that it will change possibly on examination. So at this point, we get a idea and we are thinking in a particular direction. That is as good as what you have your differentials on history, which may change on examination. The same will happen to the interpretation of the DQ. But there's nothing wrong in giving some importance to the DQ, right?
And I think it's important that on... Is this sound okay? It's important that on history we come to some conclusion so that we focus properly on examination.
Absolutely.
Otherwise we'll be groping in the dark.
Absolutely.
And also I think it's important to know at what age, at different ages, that DQ came up. How do you know static or progressive by one examination? So you'll have to ask the history, what was he doing at 3 months, 6 months, 9 months, 12 months, etc. And also what is he doing now? On examination you can only see what he can do now. But it doesn't tell you what he was doing 6 months ago or 12 months ago, which is largely the history. And what Dr. Khare pointed out is that what looks like static could be a bit slowly progressive. Now, that needs to be kept in mind, and therefore you need a further follow-up, a long follow-up. But if somebody came at 5 years, starting problems since birth, then it's very easy, whether it's static or progressive. But if it's just at 1.5 years, slowly progressive can easily make us believe that it's not progressive and static. And it's so vital, because on one hand you say, don't do many tests now, whatever damage was done was one time, and we can only rehabilitate it. Whereas the other one, we can possibly intervene with some correct measures. So that is important. Yeah.
One can never go wrong. I mean, you can't see that today what appears as global or mainly disorder of concept and understanding, suddenly after physical examination you find that his understanding is normal. It cannot be. So it definitely gives you an idea in which direction we are.
Sir, the other question was whether we should comment on the DQ during history taking or after everything is done at the end. Both. Yeah.
I would say this does not matter. Any kind of examiner will accept when you have some reason to say that. Okay. Why not on the history? Yes. And why not also confirm on examination? Many times the parents would say, oh, he can hear well. On your testing you start doubting whether he can hear at all. I know a completely deaf child whose parents were very sure he can hear well. How? I asked them, how do you know that? He said, sir, every time the advertisements come on a TV, he comes running to the living room. Oh, he can know when the advertisement comes. The real fact was, the mother was looking at the serial, and when the advertisements came, she went into the kitchen to finish some work, and the child knew that that is the time when advertisements come, so he was going to the living room. But the mother said, sir, every time he knows when the advertisements come. So he knew that mother had no interest in advertisement, so she takes a break while there is a break there. How children can be smart. Okay, so don't believe just that. So part of examination as well.
Rajesh, one question for you. Can you please repeat the difference in this global developmental delay and CP? What did you tell us? We are very confused.
So when you judge all 4 fields of development, when you find that you have delay which is motor more than mental, you are thinking of CP. When it is isolated motor, when I say motor more than mental means all 4 are affected, but motor much more, mental to a small extent, then it is CP. When it is isolated motor, it is peripheral, so it is neuromuscular problem, only isolated.
Can it also be CP?
Yeah, a small.
Yeah, small percentage.
Yeah. And when it is mental more than motor, then you are thinking of mental retardation primarily and not CP. And when it is only social and language, you are thinking of a autistic spectrum disorder.
Thank you for that clarity. Beautiful.
Okay. Now, would anyone else like to come and examine, or we get the findings from her? Anyone else wants to volunteer? Come. आप इधर आके बैठिए.
Sharad, you come on this side and just first talk without touching the baby. Just look at from a distance and say, we want a developmental examination just now. Okay, then we will even consider some part of neurological examination by inspection from a distance.
Child is very comfortable. Child is very comfortable, not sick looking, and he is taking interest in surrounding. Otherwise, on inspection,
I want you to comment on his development and comment on his CNS neurological examination by inspection. The rest is fine. I'm sure what he's saying to say is the complete inspection findings, but just now we are interested in your assessing by inspection the development of this child, and you are assessing on inspection the neurological findings on this. You get the point? I want you to say whether tone, power, nutrition, okay, coordination, abnormal movement. Can you test by looking at this child entire motor system? That's what I meant.
So right now child is able to sit. Probably he can sit without support even.
Without doing any of those maneuvers, आप गोद में ले लीजिए. What sir is asking is, okay, let me ask you one by one. What do you think is the tone of this child?
Tone is appropriately good.
Tone is normal. Because you don't find any part which is very floppy, nor do you find any hypertonia.
So what does that mean? Tone is normal in a child who has a developmental delay. So what does that infer?
The gross motor is not significantly affected.
Tone is normal. What does it mean?
Tracts are not involved. Extra pyramid.
What is the definition of CP? Can somebody define CP?
No, it's a static encephalo.
No, it's a disorder of what? Dash and dash.
And tone and posture, no?
Yeah.
So tone is normal. This is not CP. You just saw from a distance it's not CP. Okay. So it's not CP. Tone is normal. Okay.
No.
Posture is also normal.
Minimal hypotonia we may be able to pick up on examination. That's a caveat that we'll keep in mind.
And
but
just the
nothing
point
very
about
gross.
hypotonia, that if there is a hypotonia with a mental retardation, it's very severe mental retardation, not mild. Okay. So we'll keep that in mind. In fact, a hypotonic CP is considered now to be an obsolete label. It's not just an hypotonic CP, it's multiple defects that's causing hypotonia and a severe delay. So probably this child doesn't look all that delay. So probably if it's hypotonic, I would say this is non-neurological hypotonia, as I anticipate. It must be nutritional, or it must be benign, whatever.
Okay. Now, do you think there's paresis of any part of the body?
So the lower limb means, for comparison, lower limb is looking more slightly paretic to the compared to the upper.
Why do you say so?
So like
What about
So
other?
name a condition of paresis with a normal tone. He said there may be a paresis. Okay. Name a type of a condition where there is a paresis but the tone is normal.
Is there such a condition?
If you say there is no, then the tone, if normal, the paresis is not there. Okay, think that way. Okay, small little differences, yes, you can make out only on examination. But yes, if a tone is normal, power is very likely to be normal. Yeah? But the other way around can happen. Power is normal, but the tone is abnormal. Yeah, that can happen. Okay, so keep a note of that.
so language wise, he's just making barbling the noise. Otherwise, it's not just.
So you would have said that motor system is normal. Okay, power, tone appear normal, nutrition normal. Okay, I haven't tested coordination. Yes, I am testing. He's putting his hand straight there, etc. There's no abnormal movement. So I know motor system is normal. Okay. Yes. Then can I pick up a cranial nerve? Yes. I can pick up some cranial nerves. And I would say that, oh, he's looking around, his face looks alright. I saw his eyeballs moving. Okay, his mouth looks to be okay. And therefore, he has no gurgling sound there. So he has most of the cranial nerves normal. Okay, so your cranial nerve normal, motor system. Sensory system you can't and rarely required. Okay. Then what about his skull? Is he having a large skull, a small skull, or a normal skull? Well, that might give you an idea where it is. What's your impression? Normal. Looks like a normal. What does that mean? What does a normal skull in a delayed development mean?
No early affection like perinatal insult or that.
So perinatal insults almost always lead to a small skull, right? So you can say that there was nothing perinatally, right?
Okay. And no CNS malformations associated with a small or a large skull.
CNS malformation can happen. Small skull.
Okay. So now tell us what is the anthropometry of this child?
Sir, weight is 10.2 kilos, which...
What is he doing? Voice. What is the speech development? He is only vocalizing sounds coming from posterior part of pharynx, and there are no anterior sounds like bap, 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 or anything. At least not when the child is sitting. So this is like, vocalizing something like 4 months or 5 months or so. After that, we have not heard him saying that. And also he's looking at his hands and taking down and looking at his hands. What is that?
Hand regard.
Mouthing.
Hand regard or mouthing.
So what is persistent hand regard? And after what age it is not normal?
6.
Up to what age is it normal?
3 to 4 months it is.
3 to 4 months. So at this age, hand regard is not normal.
Sir,
Yeah. So
weight is 10.2 kilos, which falls between -2 and -1 standard deviation. Length is 85.5 centimeter, which is between -1 and -1 standard and median. Head circumference is 45 centimeters, which is between -2 and -3 standard deviation. Weight for length falls between -2 and -1 standard deviation. Mid upper arm.
How do you convince us head is normal or abnormal? Everything is minus some standard deviation. Is the head small, large, or normal?
For length,
He's already 1 year 10 months. So comparison of length has gone past. So convince me that his head is normal. It's very important.
Chest circumference.
Chest circumference. What's his chest circumference? Okay. Keep a note that if he's gone just 1 year 10 months, head and chest could be to some extent compared. Okay. Of course, chest has to be seen also with nutrition, etc. But yes, head and chest. Okay. And if this child's head and chest is quite divergent, at this age, the chest would have just taken over, even in a malnourished child. If that has not happened, then we will pick up something on that. Yeah. So keep in mind, and this is the time when you will take a chest circumference also. It's a good idea to keep it routinely so that you don't miss it. But after a year, that may be a good idea.
Yeah. Any other findings quickly on general examination?
No other positive findings, sir.
On general examination, nothing?
No.
Okay. So now, can you come and show us how did you look for, how will you do developmental examination?
First is gross motor. Gross motor, we can see the child sitting with support. Now I would like to make, because in history I got child can stand and walk with support, I would like the mother to do that. खड़ा करके चलाना. आप आ जाओ थोड़ा. Child can walk with support. If you leave, there won't be balance. He might fall. So there, he has not yet attained to walk without support. Okay, sure. Beta.
You're about dragging him with both hands, no?
There is wide based.
No. How do you demonstrate that he is walking with support? First, can you demonstrate that he is cruising along furniture?
Walking with support means child has to take support of something and walk, and you should not be supporting the child. It's what we call as either taking support of furniture, cot or a wall, and he is walking. Then it would be called, like how you said, babies sitting with support. I will not call it sitting with support. Mother is holding the child. Okay, I'm sure baby is able to sit with support. I'm not challenging that, but at this point in time, it's not possible to say that he is sitting with support.
So will you make him sit there and see what happens? Obviously he should sit without support, no? If he is able to walk with support.
He can sit without support.
No. Okay. What about fine motor?
Fine motor.
Do you have some cues?
You could say that he was sitting with support, but a little later you could just push him on one side here to see whether he's got lateral propping also or no, and much more little later whether he has backward prop. That's difficult. So lateral propping and forward propping after having seen that the child is able to sit on his own. Sir, is this sitting without support? But I think sitting without support, he and she can able to sit without support, not by the putting in like that position. See whether the child is able to sit without support, but he may not be able to come to a sitting position. That is still child syndrome. There are some who are bottom shufflers. They will walk at 1.5 years, so they cannot get into the sitting position. If a child doesn't crawl on his knees, there is no way in which a child in a horizontal position can come in a sitting position. But when made to sit, he can sit very nicely. Okay, so he is not able to come to sitting position because he cannot get into the walking, crawling position, but he is able to sit when made to sit. So that is sitting with support. Or sitting, even he may be able to sitting without support also. But here a little bit of push on one side and this child would have toppled. So while he is able to sit with support, he is not so stable and he has not yet developed lateral propping. That is a stage further than just sitting with support.
So perfect sitting is at about 8 months in a normal child. One sir said that propping. Second, judging pivoting. That means a child who's sitting, you give a toy here, the child turns only the trunk and takes the toy. That is pivoting. That is the perfect stability in sitting, and that is when the child has absolutely started sitting. Yeah? Okay. What about the fine motor? You have any way to judge that? You've got cubes or anything? No. Okay. Have you done any examination for fine motor?
Sir, I had given child a ball. He reached out for the object and he could hold the ball. Other than that,
have you looked at the grasp of the child?
It is complete, sir.
Can you show that? Do you have a small?
Can I give a small tip?
Yes.
For your developmental assessment, it has to be an opportunistic examination like you did your neurological examination. This child is not crying too much, but when you are doing a developmental assessment in a child who is delayed, they are likely to get very cranky. You need to have a set of toys, cubes, threads, beads, paper, pen, and all those things ready, and then offer them to the child one at a time and see what he achieves with that. and make your conclusions about whether it's gross motor, fine motor, speech, language in your own mind. Don't run through that list. Okay, now he has to walk, now he has to sit, he'll get irritated with you. So remember that developmental assessment has to be done with a kit and it has to be opportunistic. Practice that, that's very important.
So does you said his grasp is a crude grasp?
Yes, sir. Yes.
He does not have a pincer grasp or a two-finger grasp. Okay.
Then in language he makes that sound otherwise.
That's all.
Yeah.
So as sir said, that is just vocalization that puts him to about 4 months or so. Yeah. And social
he I'm not sure. He plays to him. Should we call it as playing to himself or?
No, playing to himself, okay, but before that you look for many other. Playing to himself is at what age? Plays on his own is at what age?
1.5.
So that's pretty late. So there are so many social things that you can judge before that, no? And I mean, in developmental assessment, one thing we know, there are some milestones which just cannot be skipped. So you cannot change the order of achievement. You cannot stand before sitting, etc., etc. So that is different. So what are the milestones before that you want to judge in social? For example, the best would be Tata bye-bye. So is he able to do Tata bye-bye?
No.
No. So if he is not able to do that, then he is less than 10 months. Now what about at 6 months? What can you, So peekaboo. So does he play peekaboo?
No.
Does he enjoy peekaboo?
No.
No. So then come even earlier. So does he understand no? That's at about 6 months, that general understanding. So you ask
he
whether
demands for if mother is feeding him and she stops in between, he just makes some sound to ask for
no.
some.
So that is very, very primitive. That is not. So that means his language and his social or general understanding seems to be greatly affected. Right, sir? Okay. Anything else on examination you have?
On CNS examination, there is hypotonia in all the 4 limbs. There is no axial hypotonia, and sir, I could not get reflexes. Deep tendon reflexes are absent.
Just try again.
Superficial abscess.
You will have to get the patient back here for reflexes.
इधर ले आइए.
Rajesh, there is a question for you. Are there distal abnormal movements in this child? Are there abnormal movements at all? Or this is normal?
They are not abnormal movement, but I thought there are some stereotypies or some repetitive
which would
movements
tell us that this may be an autistic spectrum disorder?
Yes.
Means
yes.
there is a higher functioning viewer who has asked
Yes,
this question.
yes. In fact, I thought he was doing some rocking movements and all that there. So there is a suggestion. Yes.
One more thing is there is he grinds his teeth continuously.
Okay. What is the technique? Last time also Khare sir described that. What's the best way to do it?
Ramya, you will have to not block the child.
Ankle also you are not getting?
I think if you have a normal power, maybe a mild hypotonia, you don't expect the reflexes to be done. That's number one. So you have to get these reflexes. They have to be there, but you are not getting them. How do you do that? So you keep on changing the angle of the knee, because you don't know in which correct angle the child is absolutely relaxed. And Dr. Khare got it just now. The point is that always anticipate whether you are finding that you are getting are acceptable, expected, and in this child they are not expected. What would you do in an examination now? A small trick to play with. Sir, I got once. I am not able to show you now. Yeah. So no question of asking what's the cause of hypo or reflexia. No, I got one. But you better show also one. Not that you just keep on doing that. But sometimes you are also tense and the child is also tense and the only one who is not tense is an examiner. So then you can't get the reflex. So it doesn't matter. You say I'm discussing with normal reflex. So,
Sir, can we?
No, it has to be.
Sir.
Sometimes you anticipate, and even if you did not get a sign, you say, no, I must get a sign.
Sir, can we enumerate the student being tense as one of the causes of absent reflexes?
Yes, I suppose so, yes.
Sir, Manik.
Good muscle tone, at least at the girdle, shoulder girdle. Okay, supporting. My hands are straight. No cross seizure in the head. Good mind, yeah. No dislocation, hypotonia definitely. A hypotonic child, when he tries to make movements because of the tone, it might appear that he has some involuntary movements like that. It may not be able to characterize. So I wouldn't say that this is a movement disorder. It may be a partly responsibility, is due to hypotonia.
Okay, Rajesh, one comment on the child's posture somebody wants to know. What is it?
The posture is normal to slightly hypotonic. So what's your summary and final diagnosis?
No, 1 year, 10 months.
Also mention fundus, also mention no liver and spleen. So just to make it complete, because that might give you a different diagnosis altogether. I'm sure you would have done it, yeah, but just keep a note of that. Even negative findings are sometimes important.
Also your assessment of hearing, vision.
So I think make a definite mention that fundus is normal. Okay, that's important. Spine, okay, bladder, bowel. Okay, so small little things make a much more impact on an examiner to say, yes, you have looked specifically for something which is not there, okay, but you have looked for it.
Yeah, simple things, maybe, undescended testes or a hypospadias also. Neurologically, you may not find it so very important, but that may make a syndrome.
Is undescended testis neurological? Just because you mention it, not very important, yes?
Could be, sir. Undescended testis could be neurological because the pulling of the testis is because of the action of the gubernaculum, and if there's hypotonia, then the testis is not pulled down, so it could be neurological.
What about large testis? Fragile X syndrome.
Fragile X is later on. It's later on. The hair, because let's come to the other end. I was talking about the hair. Pili torti, Menkes, trichorhexis with arginosuccinic aciduria. So hair gives you a lot. Autistic features and hypopigmented spots, Engelmann's. So even skin markers, hair, can give you a lot of clues for neuroregression.
And often forgotten but sometimes useful is dermatoglysis. We are not studying the dermatoglysis, but if you find that there are abnormal dermatoglysis, then you know that this is prenatally notched. You may or may not be able to put it as a syndrome, but it's likely, postnatal problem is not going to rise to abnormal term. So all small things go to make a diagnosis, etiological diagnosis.
Yeah, so Ramya, what's your summary and final diagnosis?
1 year, 10-month-old male child with normal, with apparently normal perinatal history, with multiple episodes of convulsion, most probably remote asymptomatic epilepsy, with global developmental delay, language and social more affected than gross motor, with hearing impairment, most probably a genetic or a genetic.
So without any dysmorphic features.
No neurocutaneous markers or any dysmorphic features.
Okay.
Any epilepsy syndromes secondary to any genetic cause.
Okay. So how will you investigate this child?
I would like to do a EEG to look for any pattern because of the multiple episodes of this one, and neuroimaging, MRI brain.
Okay. How will you manage this child?
So if a child comes with acute epilepsy, we will treat the convulsion with anti-epileptic drugs, and we would like to work up to know the cause of this global developmental delay, and in the meanwhile we would I would want to give nutritional rehabilitation and physiotherapy and occupational therapy and early intervention too.
This child does not have any spasticity, no? So why physiotherapy?
If we give stimulus, then
anybody? So do you need physiotherapy or you don't need for this child?
In hypotonia, we of course need physiotherapy because the stimulation therapy like. Sir, one thing, we will go with the investigation like that of cell, BERA, then of course the confirmed diagnosis for I will suspect in this child also Pelagius Musbacher because the developmental delay and some chorioarthrotoid movement is there. No neurocutaneous marker also there, and X-linked recessive male child is also there.
I thought that the investigations would probably lead, one investigation would lead to another, so I did not go much into the depth. Vera, of course, because she's already saying that there is a suspected hearing.
Rajesh,
You wanted to add in?
Primitive reflexes and planters we want to know.
Yeah.
Should we check for those?
Yeah.
planters or flexors.
Planters are downgoing. And primitive reflexes, yes, we should have checked for that.
They are not there.
You checked for that? Yeah.
If you are not looking at, if you are not thinking in terms of CP, primitive reflexes, you don't expect them to
You don't expect them to be there, yeah.
I think we need to just discuss little bit what he said. Neuroimaging is the most common investigation, which might lead to some further investigations, like some typical abnormalities might lead to an inborn nerve metabolism and so on and so forth, congenital malformation, maybe congenital infection. You might get some clue. The point is, what kind of neuroimaging would you do? Would you do a CT or an MR? Let's discuss that first and then say why do we do at all this?
I would like to do MRI in place of CT because we want to look for the myelination and gray matter, white matter differentiation.
Would you say in which kind of neurological disease you prefer a CT and which kind of neurological diseases you prefer an MR?
So in any acute event like a trauma or any hemorrhage suspected, we are in a hurry to finish the procedure very early and give the intervention. In that time, it is better to do CT.
Intrauterine infections, calcifications are better picked up by in intrauterine infections. Calcifications are better picked up by a CT. So if you are suspecting an intrauterine infection over
metabolic or genetic causes, then I think the CT would be more justified. Of course, MRI is indispensable, and definitely if we are ruling out other structural malformations, I think MRI would take precedence over CT.
MRI will be reserved for the posterior fossa, myelination, and infratentorial and cerebral edema. This.
So I thought, sir, here since seizure is a problem, we are thinking of neuroimaging. Otherwise, you do require a urinary aminoacidogram, you require a metabolic screening. That is a must. And especially in the first year, if you get a neuroregression, you would be thinking of metabolic, organic acidemias, you'll think of aminoacidopathies, and you would even have to rule out hypothyroidism. So there, neuroimaging doesn't come into play. Now, neuroimaging, CT is always preferred because it's quick. It hardly takes time. MRI takes a lot of time. But MRI picks up the brain matter better, the grey-white differentiation, the posterior fossa, the structure, and you have various modalities in MRI which can even tell you function and the chemical elements in the brain. Whereas CT is a wonderful modality for hemorrhage, for calcification, and that can be picked up very fast and you can get it in minutes. And ultrasound is a modality that we should not forget. And ultrasound picks up most of the things, except that the posterior fossa is not very well picked up. Structural abnormality still, and ultrasound is a wonderful modality. It's a bedside procedure without any radiation, and it's very good.
And so in general, you would say that a delayed development in child, largely MR would be a preferable investigation. When it's an acute insult like a TVM or an acute stroke, you might consider a CT as well, though in acute stroke MRI is even more sensitive and specific as compared to a CT, and a CT without contrast would even go down further on that. So largely what you all have said is that this child would. So let's look at largely in a developmental delay the investigation. One is an EEG, whether that's going to be helpful to define the kind of epilepsy that you have. The second is a neuroimaging that gives you an idea about some pathology, and as we said, an MR is preferable. And the third is whether you would like a metabolic screen. Now, metabolic screen would be again a first screen. Okay, so what are the screening tests of metabolic disorders? There are hundreds of tests of metabolic. You want a screening test. What does the screening test mean? I decide further which way I go. That's a screening test. So what are the screening tests? Like a screening test of immune deficiency. You don't do all that. You first group them and say, is it antibody, is it T cell, then go further. So what are the screening tests for a metabolic disorder?
Blood gas analysis.
Pass on the mic till then she answers, yes.
Blood gas analysis, then serum ammonia, then lactate.
Urinary ketones. Urinary ketones.
When you talk of blood gas, you tell me what acidosis and alkalosis. Where do you get alkalosis? Which metabolic disorders? Hyperammonemia?
Yeah.
Acidosis? Acidosis? Organic acidemias. What else do you get in organic acidemias? Neutropenias, osteoporosis, frequent fractures, propionic, methylmalonic. Those are the acidemias they're talking about, where you also get hyperammonemias. How do you do an ammonia? This is a very tricky question. Why not a venous sample?
Any arterial and venous, but without any tourniquet.
Why no tourniquet? Why no pumping? Ammonia is produced in? It's even produced in the muscle. Glutamine to ammonia. In the kidney, glutamine to ammonia. In the liver, it is metabolized by the urea cycle. And why is a hyperammonemic state bad for the brain? Why are you worried? Very high ammonia levels, you give significance. A borderline ammonia, you have to correlate with the other findings. Okay, so when you have a high ammonia, why are you worried? Easily gets into the blood-brain barrier and gets converted to glutamine in the astrocyte, gets into the astrocyte osmotically, extremely active. So you get an acute edema and you can herniate very high levels. That's why it's an emergency. Fine, never use a tourniquet, never pump, and it should be a free-flowing sample. and assessed immediately, correlated with other reports. Fine, so you can get it. If the kidney is not functioning, yes, it can build up. Liver, it's a problem. OTC is one condition, ornithine transcarbamylase, which can present at any age. Okay, with an intercurrent infection, usually seen in males, that can come with hyperammonemia.
So I think for me, screening test would be ABC. Then you will do blood sugar. So don't forget the blood sugar. Then you will do a urine examination. Okay, urine for ketones largely, sugar as well. Then go further on to say what metabolic disorders you would have. So largely you would just look at these 2-3 first things and then decide where you fit in and the subsequent. The point that I want to make is that it's not easy for a clinician to finally label the cause of such a delayed development. So how would you put it in an examination? You would put in a group and said, what investigation? So you have 3 types of investigation. EEG is one. Okay, sometimes an EMG as well, because some of these central neurological disorders may also have a peripheral neurological finding. And if you have that, then that also comes in. Then you have, of course, so electrophysiological, neuroimaging, and a metabolic screen. So keep this in mind and then say that, then we march on further to say what exactly it is. I suppose that's the way you go.
In metabolic screen, you divide them. The metabolic screen for acute disorders and encephalopathy is different than a chronic disorder like this. So here you may not be much interested in hyperammonemia and ABG, etc. So you are in this case is interested in plasma and urinary amino acids. Then MPS urine examination, glucose and sugar, and maybe leukocyte enzyme, etc., which is a specialized investigation if there are leukodystrophies or diseases. But basically, plasma and urinary amino acids, sugar for urine, and MPS urea. These are 4 screening disorders which will come first, followed by leukocyte enzymes if necessary later on. While those for acute disorders are entirely different, which you mentioned.
So why EEG in this situation, the current, we are not suspecting any Rolandic, any specific syndrome, herpetic, and not we are thinking about the therapy like the EEG suggests therapy. Why EEG in acute episode?
The thing is that this is not an acute episode. It manifests acutely. It's certainly a child who is likely to get seizures again. So I want to see primarily one, is it any syndromic epilepsy? That is number 1. Okay. Second is, it's a good idea to have a baseline EEG before I start my anticonvulsant because I don't know what I expect in this child. I expect in this child a poor control of seizure to a large extent. More the brain damage, more is the likelihood of a poor control of seizure. And then I need to look at again maybe another EEG to see whether I get any further thing. So one is an EEG would be a reasonable idea. As far as the metabolic disorders are concerned in this child, I may not run through that right now because I'm not strictly expecting that. Neuroimaging, yes, because I might get an idea of what happened in this child in terms of neuroimaging. So I suppose that what I wanted to say is that we have 3 groups of lab investigation in a delayed development. You pick up which one you would like to do, sometimes maybe all, and then march further whether you want to do something more specific.
There are some syndromes which are associated with hips arrhythmia. So that's how the EEG helps. And same thing, leukodystrophies. We are not talking about this case in general. Leukodystrophies can come with peripheral neuropathies. That's why the EMG comes along with it. And lactate and pyruvate.
One more investigation which is not an investigation but a very useful workup is to list all the abnormalities in this particular child because it's a rare thing and literally open the book and look at what are the other features which is matching it. Because this is likely to be a rarer disorder, we don't know all of them, and you open a book like metabolic disorder book, and you literally map out what is there in this child and what is given in a syndrome which mimics, and often in maybe 3 out of 10 you will be able to come to a reasonable diagnosis. Just so it's not that investigation, but it's an investigation to be done in the office practice, but very useful.
I think we'll stop this case here. One tip, sir, is if you get a peripheral neuropathy, entrapment neuropathies are pretty common in mucolipidosis, mucopolysaccharidosis, especially when you have it below 10 years of age, because we were discussing NPS too. Sir,
I think just one quick exercise. How would you counsel these parents? Okay, this becomes very, very important issue in a child like this. Who would try to counsel the parents? Would somebody try? Would you try to counsel the parents? Just give a try. Okay, then we'll all put ourselves. None of us may be complete. None of us may be the best. But doesn't matter. How would you go by it? Just try counseling this. Yeah. Somebody? Sir, do you want to do that? Just give a try. Doesn't matter. You know that the problem is at the head and not at the toe. So that's good enough, isn't it? Would you try that? Yeah, please. Yeah.
So first I would like to highlight a very important feature in this child's presentation is that there was developmental delay since birth. So first I would like to tell the mother that probably this is we are looking at a very long-term illness or probably a lifelong illness that this child would probably have, and whatever complications that are there in this particular illness, they are probably expected or probably anticipated. One, and whatever says if seizures are one of the complications, we have to also explain that in the background of a developmental delay, the seizures could be not controlled adequately even with the appropriate medications. That is one, and probably this child needs a holistic care approach and rather than a simple unified therapy. And a regular follow-up is more important than treating this child at one admission for a particular complication. I would like to highlight these 3 points.
Well, I think what you did was you told us the principles of counseling in this child. What I would have said is that unfortunately your child's brain is growing a bit slower than what we expect. But it seems to be growing. Now we don't know how far it will keep on growing, but we will have to follow it up. It looks like that it has started almost since birth that it was not growing well. There is no clear idea whether this child is born with some defect that we could not find, or whether there has been some insult to the brain that caused some disturbance and therefore your child's brain is not growing as much. What today we know is that there is no disease in the brain today, so we have no treatment specific for this problem, but the nature will improve this child, but we should help nature to further speed up the improvement. How will you do that? So you have to teach. Do you normally teach a child to walk? No, he learns to walk by himself, but your child will need to be taught to walk, but after all then he can walk. So normal child speaks on his own, hearing sounds. I want to confirm that he can hear. If he cannot hear, then I will have to set that right. But if he can hear, then he will have to be taught how to speak. Whereas a normal child learns by himself. After all, you can teach him. Now depending on, not every time when you teach him once he will understand. So sometimes you will have to teach him many times for him to understand. That means tell them that there would be a slow progress, but if a child does not understand, you have to make him understand by telling him several times. So don't get worried. I know there is a problem, and the child will improve slowly. That is what I expect. Let's start doing this for a while, and let's see him after 3 months. Now as the time goes and all these methods of teaching start working, I will better know what must have been the cause. I will also at that time know what is expected after a year or two. Don't commit. Okay, she is happy to know that the child is improving. She is happy to know that she will have to work hard for the child to improve, and you have not said whether it's bad or good prognosis, etc. I think that's the way to counsel. What is important of counseling? Tell the truth, but say it in a manner that it is palatable, acceptable. Encourage the mother to do good for the child, and remember every child can do better, doesn't mean what is better. If I was consistently failing by 10 marks and now I fail only by 5 marks, I have improved. Okay, so that means improvement. Okay, hopefully one day I will pass. So every child will do better. I haven't said when I will pass. But sir, last time you failed by 10 marks, this time by 5 marks. I think you are doing better. Why not do something more? One day you will pass. I think that's the philosophy. Yeah? I think we will do that.
Sir, one more thing, sir, in the investigation part, sir, I feel that apart from the metabolic cause that we had discussed, so the investigation for the same, so I think a fish analysis and a genetic microarray is very important because there are a whole spectrum of these microdeletion syndromes which have not been described classically. So I think that should be one of the...
Absolutely, I fully agree with that. Yes, that when you don't know what it is and it's syndromic, it could be a genetically determined syndromic, and that's the only way to know is to further see whether all that we know is that there is no Downs or there is no trisomy, but that is all. We don't know whether there are small defects. I fully agree with you.
That's also called fishing for a diagnosis, when you do fish. Rajesh has some very quick...
to know that if you fish for a diagnosis, you ask for a fish. Yes.
Okay, Rajesh, some questions for you.
Thank you, Ramya. Can we have the second case meanwhile, the second present?
Are you avoiding my question?
No.
Okay.
I'm just speeding up things. We are getting late.
Okay, the first question is, how do you differentiate in neuroregressive disorders between grey matter and white matter? Can you give us few lines about this? Neuroregressive. This child does not... Yeah.
So basically, you look for the symptoms present. So symptoms of grey matter would include seizures, scholastic backwardness in a bigger child. So those kind of symptoms related mainly to the cortex. Whereas the white matter disorders will come with tone, spasticity, all those problems. Yeah.
So this child had hypotonia. Why didn't we do that 180-degree test? We should have done that, right? Yeah. So that's one thing which we missed. And at what age do we start doing this 180-degree test? From when do we start and when do we stop doing it?
It's in newborns, infants.
Yeah, it can be done from 2 to 3 months. It's 180 degree is not one particular test, but as you all know, it's just a series of maneuvers that you do to do a neurological examination of an infant, if I can say. At 1 year, 10 months, because the developmental age was slow, we could have done that, but it becomes more difficult to do ventral suspension, axillary suspension, and various postures to...
It's also, Tushar, would it be decided by the child's weight also?
Yes, and your biceps.
Yes. Okay.
Just before, can I make one quick
Sure.
comment? When we said about fish, it's a very great test to do. But as Anand said, you must know what you are fishing for. You cannot say, I want fish for this. You have to say, fish for Williams, fish for XYZ. Okay? So you must know you must suspect something for you to fish it.
Don't fish for fun. Okay. So our final diagnosis was an antenatal insult and this was a static problem. Is that right, Rajesh? After all this discussion, we are a little confused.
Yeah, means at the moment it looks static, but Khare sir made that point that if he goes into developmental arrest, so to say, and doesn't go on developing further, then it becomes progressive.
Okay.
So we are looking, that's one. And second is the cause is prenatal, but whether it is genetic or whether it's metabolic or syndromic, we don't know. We will have to investigate.
There is another question which is slightly unrelated. Are you totally ready? Take a few deep breaths. I'll finish it now. When do I suspect long QT syndrome in an epileptic child? And when should we do an ECG? Well, I'll answer this quickly. A long QT syndrome usually will have a familial history. They will have syncopal attacks. And you will suspect it based on red flag signs for syncope as a screening test, unless you have a positive family history. Both are not related epilepsy-wise. He may incidentally have epilepsy, which is another story altogether. We are ready.
My patient, 9-year-old female child, 4th by birth order, born of 3rd degree consanguineous marriage, a resident of Kurla, hailing from Aurangabad, Muslim by religion, brought by informed by mother with complaint of pain in both the legs 10 days back and weakness of the lower limb since last 10 days. Patient was apparently alright 10 days back when she had pain in both the leg and lower back region, which was acute in onset, severe dull aching, which was there throughout the day, more during night time, to such an extent that child was unable to do her routine activity. Child was given some painkiller medication. This pain subsided after 2 to 3 days. Mother also noticed that since along with the pain, child also had the weakness of lower limb in the form of she was unable to walk properly and has an abnormal gait. Over 1 or 2 days, the weakness progressed to such an extent that child was unable to walk without support, and she was unable to get up from sitting position. Although child was able to get up from supine to sitting position. The weakness was same over next 1 week. After that, during when the weakness started, child was admitted in the hospital. She was given IV medication. Slowly, since last 1 to 2 days, the weakness has improved in the form that child is able to get up with support from sitting position. There was no history of weakness in upper limb. On inquiry, mother also complained that at the onset of illness, child had complained of increased frequency and urgency of micturition, but these symptoms resolved after 2 to 3 days. There was no history suggestive of cranial nerve involvement. There was no history suggestive of sensory loss or any tingling or numbness in the lower limbs. There was no history of fever any time during the illness. There was no history of altered sensorium or any sign suggestive of raised ICT. There was no history of COX or COX contact. There was no history of similar episode in the past. There was no history of diarrhea or cough cold in recent past. In birth history, mother is ANC registered and immunized. She has received supplements. It was a full-term LSCS in view of previous LSCS. Birth weight was 2.7 kg. There was no history of NICU stay. Child has received BCG vaccine and...
we can skip that. And anything relevant there?
No.
Okay.
No.
Fine. So...
No, she has received last immunization at 9 months after the achievement.
Okay. And she is now 9 years. Okay. Yeah. So who will analyze the chief complaint of pain in both the lower limbs, right? For 10 days.
Pain was there only for 2 to 3 days.
2 to 3 days.
First 3 days.
Okay. So how will you approach that problem? How will you analyze that? So first we want to attempt to find the anatomy of this pain. Somebody comes to us, go back in time. So somebody comes to us just for 2-3 days of pain in lower limbs. At that point, this child has not yet developed weakness. So how will you analyze that pain?
It could be muscle pain, or it could be joint involvement, or could be a sign of neuropathic pain.
Okay. So how will you clinically analyze or differentiate between these different pains? What else? Muscle you said, then joint you said, then nerves. Anything else? Neuromuscular junction. That is weakness we are talking of.
Just for anatomical differentiation.
Correct. So that is when we talk of weakness. Just now we are talking of pain. So if somebody comes to us with pain in the lower limbs, what else is possible anatomy? Can it be the bones? Yes. Okay. Can it be blood vessels? So arteries and veins? Yes. Okay. So now how will you differentiate between all this? So quickly take the blood vessels first, or take anyone, take blood vessels. How will you differentiate arterial pain? How will you differentiate venous pain? Clinically, quick, one point and then we get on to anybody.
Arterial pain would be very severe.
One is it would be severe, so ischemic pain is very severe. What else?
Acute presentation.
Okay, acute. What else? When will it come up?
Claudication.
Intermittent claudication, typically. So that means it will come up on exertion or physical activity. Okay, and then severe and all that. So that's your arterial. Then venous.
It will be associated with edema or swelling.
Okay, so could be associated with edema. And when will it come up?
Dull aching, it will be
dull aching.
it will come more in the evening after a prolonged period of time.
So prolonged
immobilization.
Okay, prolonged immobilization. Fine. Then, so this was blood vessels. Then you said muscle. How do you differentiate muscle pain?
Tenderness.
So one is tenderness. What else?
It will be generalized. It can be associated with prior fever or any
So generalized or localized, preceding fever or no?
Preceding some exertional activity.
Okay. Okay. So you know what used to be called growing pains, as an aside. Where is the anatomy of those pains?
Bone.
Which organ does it come? Which part does it come from, and why?
Epiphyse.
No. It's not really growing pain, so no epiphysis or anything.
Lower limb and mostly in evening.
Correct. What I'm saying is, does that pain arise from the bone?
No.
So it arises from muscle. Why? Why? So current theory is hypermobility. So because of hypermobility or laxity, the muscles have to work harder to maintain stability. So that's why after a period of prolonged, fine. So why I brought that up is muscle pain. Why do you get headache? When you get headache, tension headache, and you press the head, you feel better. So that's a tense muscle. So muscle pain often feels better on pressure unless the muscle itself is inflamed like a myositis. Okay. So that was muscle pain. Then bony pain. Can this be bony pain? In this child, pain in both lower limbs, can it be bony pain? Yes?
Yeah, very much yes. Leukemia starts like that. Bony pain.
If it is, considering leukemia, I'll be considering the bony pain will be both in the upper limb as well as lower limb. Here it is in this case, it's only in the lower limb.
So bony pain is either due to generalized disorders like say osteoporosis etc., where it will be generalized, or it is due to a localized problem. So localized problem may be an infection, osteomyelitis, or sir said leukemia or some such thing, where it will not be just like both legs but both lower limbs. That is very unlikely to be a bony pain. Okay. What about joints? You have to specify on history whether it is joint or the whole limb that is paining, right? So how do you make out that this pain in this child is neurological? We seem to have ruled out muscle, bone, blood vessel.
Sir, neurological, probably distal muscles are more involved. In myopathy, it is more of proximal muscles involved.
That is about weakness. Again, we are talking of pain here. Okay, dermatomal distribution.
Rajesh, if they don't use a mic, you repeat what they are saying.
He's saying dermatomal distribution. So that is, if there is pain along a particular dermatome, yes. Here there is pain along both lower limbs. So that's not really a dermatomal distribution.
I'd like to ask the history.
In this child, you would have looked at the another way. Pains are pain. Any pain is of four types: inflammatory, neurogenic, vasogenic, psychogenic. You have to fit in every pain in this. This is not inflammation straight off. No swelling, no tenderness, no pain, no redness, etc. So this is non-inflammatory. Vasogenic we already said. How arterial, venous, so that's out. It's not functional till proved otherwise, so it is neurogenic. So you start saying that this is a neurogenic pain. Okay, then if you get some more idea, what is the neurogenic pain? Okay, it will not be different whether you press, whether you massage, Okay, whether you move, okay. It may be localized or it may be bilaterally generalized. So here now we are sure it's a neurogenic pain. Neurogenic pain in the both lower limbs. So then bilaterally symmetrical neurogenic pain. What is the neurogenic pain? Where is it coming from? Can it come from anterior cell? Can it come from nerve? Can it come from muscle? Can it come from neuromuscular junction? Where does it come from? The muscle acute onset is a myositis. It's an inflammatory pain and not a neurological pain. So that is ours. So also neuromuscular junction which comes with a weakness. So we are left with anterior onset or a nerve. Every time in such a case we only deal with these two. Is it polio or is it polyneuritis? Why? Because only two conditions cause neurogenic pain. Does anterior onset cause pain? No? Are you sure anterior onset doesn't cause pain?
So does SMA have pain? Does spinal muscular atrophy have pain?
No.
And does polio not have pain? Polio does have pain. So what's the difference? Both are anterior onset. Okay. And further going by, one may have even the fasciculation and the other doesn't. Both are anterior onset. One has pain, one has no pain. One has fasciculation but no pain. Another has no fasciculation but pain.
So in polio there is inflammation of the anterior horn cell. Why in spinal muscular atrophy there is atrophy? If there is
Degeneration.
no pain, degeneration.
So one is an acute onset disease. Another is a slowly progressive chronic disease. Okay, it's only in a slowly progressive disease that you get fasciculation. In an acutely dying anterior onset, how can you get any movements at all? So fasciculation means a slowly progressive anterior onset. And in polio, there is some anterior onset which are in a stage of irritation. They are not destroyed. Those which are destroyed are paralyzed, but some are in a stage of irritation. So you get pain. Typically, meningeal signs, neck stiffness, back stiffness, head stiffness, TA tightness are all evidences of that. And therefore, but it's not common. So we need to really look at this child as neurogenic pain, either nerve or the anterior. Now when you say nerve, you go further and say it's not just the peripheral nerve. It could be further close to the anterior, close to the spinal cord itself. So is it a root? So now you go further and say, is it nerve, is it root, or is it anterior?
So actually the roots are the ones which are really painful. Even in poliomyelitis, it's the inflammation of the cord, and though the symptoms are of anterior horn cells, the posterior nerve roots are not totally spared. Their symptoms are not in the form of weakness. So there is at that time involvement of posterior nerve also, giving rise to muscle spasm and pain. So pain is as a result of radiculitis. Radicals pain, the nerves tingle.
Is it?
Yes.
Is it the muscle spasm causing the pain or the radiculitis in poliomyelitis?
Both. The muscle spasm is also there, but there is radiculitis also in pain in the initial stages of poliomyelitis.
What is important to remember is the cardinal symptom and the localization. So as sir said, roots pain, so nerve roots pain, nerves tingle, and anterior horn cell atrophies. So these are the cardinal symptoms that we should remember.
Rajesh,
Spasm is also
Dr. Manglani has some comments to make. So I think it's been discussed. She says leukemic pain can be localized. That's one thing. And she's also mentioned that she's enjoying this from the comfort of her home, and she wants to thank Dr. Vijay Evle. She said it 3 times, so I had to put it in.
Yeah.
I thought radiculopathies were shooting pains.
as a result
Flexopathies, radiculopathies, you have a shooting, you have like a sciatica.
No, I mean they need
So
not
is
be.
it
They
only
can,
the muscle spasm in poliomyelitis that is responsible for the extreme pain, because you have pseudoparalysis?
yes, but the
Initial.
spasm is also as a result of. It's not the muscle itself is not involved primarily. The spasm is neurogenic in origin because the muscle is spared. There is no myositis in poliomyelitis. To give another example, In radiculitis, there is muscle spasm as a result of which we have a abnormal straight leg raising test, which is a hallmark of signs of radiculitis. Now here the spasm is responsible for straight leg raising test, and the spasm is of the posterior spinal muscle, which is as a result of radiculitis. So in this particular child, if there is neurogenic pain, then certainly it's not because of peripheral nerve pain, because they don't produce that much of pain, but it is as a result of associated radiculitis, spinal radiculitis, that this particular child has pain. And the point of proving this would be to do a straight lacing test in this particular child, which would be positive in this particular. And therefore, even in the diagnosis, if it is suppose Guillain-Barré, then it is radiculoneuropathy. Radiculopathy is the result of, is the cause of pain, and neuropathy is gives rise to the weakness. I will confirm regarding association of radical involvement in polio, but to the best of my knowledge is the myelopathy, and therefore involves all part of the spinal cord.
So we have said that this child has probably root pains, and then this child has gone on to develop weakness of both lower limbs, which you described. So just 2 points that, we'll go fast over this, that at this point, while taking the history and while analyzing, we should decide whether the child is not moving or not walking because of the pain, or there is actual weakness of the muscles. So you ask for that by other movements in bed, etc., whether the child is able to move or not. Okay. Now you made one point that this child could get up from sleeping position to sitting position, but could not get up from sitting to standing. What does that signify?
Truncal weakness is not there, but there's a proximal lower limb.
Yeah, excellent. So truncal weakness is not much, and it is the upper proximal muscle weakness of the lower limbs which is there. Fine. So now to get it a little faster, what is the anatomy? We have decided that the anatomy is the nerve roots. Can it be spinal cord? You said there were some, so that's why I'm coming to. You said there were urinary symptoms. So can the anatomy of this problem be the spinal cord? So can this be a cord lesion?
And what urinary symptoms?
Increase frequency and urgency.
There was never any retention nor dribbling. So is urgency and frequency a neurological complaint, or is just a bladder irritation? Is hyper irritable or hyperreactive bladder?
Spastic involvement bladder can cause increased frequency or
at the cost of oversimplification, once the child has achieved bladder control, if he goes back again to the previous state, then it is a lesion above the pons. That is what we call uninhibited bladder, meaning the child cannot control when to pass and where to pass urine. If the lesion is below the pons but above S2, then you say it's an upper motor neuron lesion for the bladder. And just like any other upper motor neuron lesion, you will develop the child will have a spastic bladder. Below S2, you will say it's a lower motor neuron lesion, and just like lower motor neuron lesion, you will have a flaccid bladder, which will be, for simplification, will have no sensation, will be flaccid, and will be overflow incontinence. The only one more point we want to make here is that as in spinal shock, we see the child who gets a stroke and has flaccidity. That's the time the bladder also, you imagine it as flaccid bladder. So otherwise you would get later on you will have a change in the tone of the muscles. Same way you will have change in the bladder pattern. So that's why you have to catheterize a child with TBM in early stages when he is in spinal shock. And later on he will eventually develop a spastic bladder.
Rajesh, I am being nagged here. So will you, because some high functioning people keep asking questions again and again till it's answered. So the question is, how did we conclude about this being a neurogenic pain? Can you revise it for us quickly? Of the 4 categories, inflammatory, vascular, neurogenic and traumatic. How did he come to this
There are
conclusion?
two ways. One was, as sir said, whether it's inflammatory. So there is no fever, there is no swelling, etc., no redness. So this is not inflammatory. Then vascular, we said there is not arterial and not venous because of the features that we discussed. Arterial on effort, acute, sudden, severe, intermittent. Venous on prolonged immobilization associated with stasis, edema, etc. So all that, so there is not vascular. Psychogenic, as sir said, we can only prove later over time, and therefore this was neurogenic. Further addition of neurogenic is that neurogenic is not affected by movement, not affected by palpation, by pressure, how a muscular pain would be relieved, or an inflammatory pain would be aggravated by pressure. All that doesn't happen. Neurogenic pain is constant, severe, and there all the time without any other visible abnormality. So that's how we concluded this is neurogenic.
Thanks.
So okay, so now can this be a spinal cord lesion?
I would like to confirm with examination.
Okay, but on history, some points in favor or against?
Bladder involvement is there, so it could be a spinal cord lesion. And sensation is preserved, so less like.
So there is no obvious sensory abnormality which you expect in a spinal cord lesion. Okay. Okay. So on history, what is your analysis now?
It is an acute onset, progressive weakness. At the most probably at the level of nerves or axon.
Most probably at the level of the nerve roots, yeah, and it is progressive over this 8-10 days, okay. And what do you think is the etiology of this? Just broad groups. So again, the same. Is it degenerative? Is it inflammatory? Is it neoplastic? What is it?
Inflammatory. Very acute onset.
Okay, so it's acute onset. What else?
Yes. Associated with pain and.
So we said just now that it is not localized to a particular area, so it is not ischemic or anything, or not a vascular origin. So therefore the etiology is either inflammatory, mainly inflammatory. What about degenerative or demyelination? What are the features, clinical features that we see in degeneration or demyelination? Anybody?
No, degenerative, there will be atrophy of the muscle.
Degeneration is slow, it is not so fast, so that's why it is not degenerative. Okay. So anything else in history? Okay. So you want to examine this child?
So I want to ask one question. For how long is the duration of spinal shock? For how long we can say that this is a spinal shock? And
I don't think there is a duration defined. 24 hours only.
After 24 hours, after the neurological insult, you can say that the actual manifestations of a particular pathology will become more evident. Because if in the first 24 hours of any insult, a patient is in spinal shock.
No, but is it that a spinal shock cannot last more than 24 hours?
The usual temporal profile is 24 hours. Thereafter, examination of a patient and concluding, say for example, whether this is hypotonia or hypertonia. We all know that in spinal shock there will be some amount of hypotonia. So, as the patient evolves out of hypotonia, out of the spinal shock, then you can assess the true tone
Agreed. I'm not sure on this, but my concept was that there is no fixed duration of spinal shock. So when you don't get a finding like the tone abnormality, etc., which you said, which you expect because of the overall picture, you label it to the phenomenon of spinal shock, and that is why you are not getting that finding. Yeah. So can we quickly examine this child?
So does this child said that it's a radiculopathy and a bilateral. Okay, you don't talk about peripheral neuropathy. If you talk of peripheral neuropathy, you have many other etiologies to talk of, like a toxin, like a drug, like an infection. So this becomes straight away an immune-mediated disorder. By saying bilateral, there is a generalized clause. Radiculopathy. I think that's important. So here you will straight away say that there is a bilateral acute onset. Again, acute onset is what? Trauma, immune, allergy, etc. So immune-mediated acute onset bilateral radiculopathy is the diagnosis, and therefore by that we call it as an ascending pulmonary or GBS or whatever.
So was there movement at the toes in your history when you asked? Somebody wants to know, was there movement at the toes? There was. Why is this important? To localize whether it's proximal or distal. So that was a question which was asked, which is relevant, I think.
No, but I don't know whether toe movements are also affected with distal, because they hardly require any power, so toe movements can still be
Absolutely,
present.
sir.
At ankle, etc., I will attest.
Yeah. The point which is being made is that we should try to localize whether it's proximal or distal even on history.
Yeah.
Okay. Tell us your examination findings.
Dr. Mamta Manglani says spinal shock can last forever and there is no time limit for that.
Correct.
So I think that's an important message that's come.
Tell us the positive findings and then we'll quickly demonstrate them.
In CNS, so positive, and right now she has a power of more than 355 at both the hip joints, but there is some weakness at the hip joint. But knee and ankle, this power is almost normal. There is the reflexes in upper limbs are 1+, but in lower limbs, knee and ankle reflexes are absent. And there is no cranial nerve palsy.
Okay, so can you quickly demonstrate power at hip joint?
ये सीधा रख के ऊपर कर.
So what are you demonstrating?
It's against the gravity. It's definitely more than 3/5. ये वाला सर.
Is there pain?
No.
So sir said we were expecting pain on straight leg raising, which is not there. So any explanation? Under treatment, recovering, so that's why there's no.
And should not the leg be raised a little more, Rajesh? Yeah, for you.
Also, what we expect pain in radiculitis and not necessarily in a AIDP or a radiculopathy that we say. So in Guillain-Barré syndrome, very rarely you will, almost never you will get an SLR positive. The pain, in fact, between acute transverse myelitis pain and GBS, when you are trying to distinguish between the two, if you get symptoms of pain, or sensory symptoms, but no sensory signs, then it is GBS. If you get sensory symptoms and sensory signs, then you think in terms of transverse myelitis. Okay? Just to be clear, you may get symptoms on history of pain, tingling or numbness, which can all happen with GBS. But when you do sensory examination, very rarely you will get sensory signs.
No, about sensory signs, you're absolutely right, but we'll check on this. But I think I remember Udani sir teaching us that in GBS, SLR is very commonly positive.
Okay,
but we will check on that. We will check on that. I will.
But Rajesh, I think we should do the dorsiflexion and put a stretch, even if we are not elevating it to the full extent.
Yes.
So that will definitely tell you if there is nerve root irritation.
Right.
Dr. Arpita Thakkar says there are 4 phases of spinal shock. The first 2 phases have hyporeflexia lasting for approximately 3 days. Later hyporeflexia with spasticity comes up. So I mean it's open. It's not 24 hours, but it can be longer, and we take that. The other question was, while we are at it, what are the signs of degeneration? The answer to that would be that there are no signs of degeneration. Degeneration is a process. It is a gradually progressive thing, and that you pick up on the history and not on a physical exam.
Slowly progressive loss of function, you think of a degenerative process.
If you see fasciculations in the muscle, then you will think of anterior nerve cell degeneration.
Okay. Can you demonstrate the reflexes? Wider swing of your hand. Okay. Any other findings? That's it, right?
What about the general examination in a child like this? General examination. Would you look at the respiratory rate? Yeah. Okay, so don't forget that. That brings in also a pulse range. Would you look at the blood pressure? Okay, so few things add on to our neurological examination, and I think it's important to look at those things at all. It could be a thing. Would you look at her voice? Why? Why do you want to know whether she has a voice?
Bulbar palsy.
So what palsy? Lower cranial nerves. What? Lower cranial nerves gives you poor voice? Why should she have a poor voice? Come on, not respiratory muscle weakness. How can you forget that? A good sign to pick up. Respiratory muscle weakness, there is a hypophonia, even sometimes aphonia, which makes you now look at very carefully whether her muscles are working at all, and that's important. Respiratory rates are not high. They don't complain of breathlessness, but when you look at them, they have a tachypnea. So don't forget about tachypnea. Again, like in the last case, mention negative findings. Blood pressure normal, respirate normal. Okay, which means that you are telling the examiner that you have looked at. Cranial nerves, of course, because cranial nerves could be involved in any polyneuropathy, and therefore mention all that negative. But don't forget some of these important things. For an examiner, they are very important. How can you miss tachypnea? How can you miss hypertension? Okay, you know everything else. That's not right. Yeah. So.
The type of breathing, for example, when she takes a deep breath, the abdomen just doesn't come up, telling you there that there is impending diaphragmatic paralysis. This is an emergency because this child will almost go in for respiratory support. Also, sometimes there may be not much of tachypnea if the muscular power is poor, but there may be poor excursion, and also, as Sir said, sensoria. sensorium can be affected because of two things. One is hypoxia, and if this child has affection of sensorium right from the beginning, its state takes us to acute demyelinating encephalomyelitis. In Guillain-Barré, you should not have any involvement of higher functions. So higher functions should be astutely inquired into in the history and looked into. The causes may be different.
Would you do a CSF in this child? Why?
We should look for the albumin cytological dissociation and other for the transverse myelitis, aseptic.
Two questions. At what stage of the disease you get that? And second, it may be poliomyelitis. And you pushed a needle. Are you causing harm?
What sir is asking is
in polio you won't like to put a needle somewhere, right? Yeah. How are you sure? It's just an imagination. GBS is an imagination so far. You are not proved upon. Okay. So who will take it? Which stage of GBS you get that?
It's after the second week of the disease, when the degeneration is complete and the regeneration starts. And
okay, and is cytoalbuminous dissociation specific to GBS?
No.
So where else can it be seen?
It can be in subarachnoid hemorrhage.
So any immunological disorder it can be seen, right? Okay. And what about the second question? Is there a harm in putting a needle there?
While doing CSF, we are piercing the ligament, not the muscle, so it's not harmful.
Very good.
Very clear. You are not damaging the muscle at all. Don't bother about it. Yes, even in polio, if you did it, it did not do any harm. Only in polio, sometimes what used to, now under polio is almost extinct, that when the child struggles, it's a muscular exercise. And dying anterior cells would die. So that's why you don't want to, but her answer is perfect. You don't injure the muscle at all, right?
So the assessment of autonomic nervous system, I thought postural hypotension was more important than hypertension, and retention could be again an autonomic nervous system, and
pachycerebrally.
10% of GBS can have urinary retention or urinary symptoms.
Okay, now we'll just quickly have a look at the gait of this child.
Shoulder abduction is one very important movement that you must check in GBS. Just adding to what sir said just now, because C5 is a nerve root for abduction of the shoulder, and that's the same nerve root which supplies the diaphragm.
Yeah, so anybody wants to describe the gait? You can do it yourself.
Waddling.
No, this is not waddling gait. This is not waddling gait. How will you describe this gait?
It's an antalgic gait.
This is not antalgic gait also. Antalgic is a painful gait, no? So it's a limp. Antalgic gait is always with a limp.
In the context of the case, what we were closely looking at is what is the degree of weakness, and she was being supported, and I don't know whether unsupported she would be able to walk at all, number one. Number two is whether the heel was touching the ground first or whether the toes were touching the ground first. If there is a distal weakness, I would have expected the toes to be touching the ground first, and then that would have stumbling or something. But even after watching carefully, I did see that the heel was touching the ground first. Both the entire sole was
Almost
touching
it
more
was
or less
at the time. Yeah, it was like a flat steps rather than a heel first
But
and
yeah,
that.
but it was not something where the touch, toe will touch first, which will make her sort of tumble.
And she was putting very short steps. So cautious, absolutely. So it's a cautious gait, and these were the observations. Okay. So now, finally on examination, what is your summary and how will you sort of summarize the whole case?
It's an acute onset, acute onset progressive flaccid paraparesis without involving sensory, without any sensory involvement or cranial nerve involvement. Most likely,
Which has recovered, no? Which has partially recovered on treatment. Okay. So most likely,
acute inflammatory demyelinating disease.
okay. So why not poliomyelitis?
Asymmetrical involvement is there.
Okay, asymmetry. What else?
What is asymmetry? One leg affected more than the other. And if it's an extensive polio, is it symmetrical or asymmetrical?
Asymmetric means one side leg and one side upper limb.
Extensive polio affecting all four limbs, symmetrical or asymmetrical? And here the lower limbs involved, upper limbs not. What? Symmetrically. So, asymmetrical means even in the same limb, not all muscles are equally involved. That is symmetrical and asymmetrical. So, polio is always asymmetrical. Even when it's extensively involved, all four limbs, not all muscles are equally involved. That is asymmetrical. Whereas here, all will be symmetrically involved. So, symmetrical doesn't mean just both sides or both sides. No. That is asymmetrical.
If you compare muscle to muscle on either side, if there is a mild difference, it does not make it asymmetrical. As used by one of the authors, it is qualitatively asymmetrical, if not quantitatively. So grade 3 plus here and grade 3 on right and left doesn't make it, but qualitatively she has a symmetrical. I think 2-3 words are very important: acute onset, progressive, motor weakness in this particular child, without much objectively demonstrable sensory movement in this child, without affecting the upper limb, cranial nerve, and also the higher centers, and of course areflexia is still there, it is still persistent, and perhaps bladder and bowel disturbances absent. I was not able to. The bladder that you are telling is bladder vivacity, passing urine every now and then. Now, unless it is an overflow retention, such a thing would not be a neurological bladder. I don't know why she was passing urine every now and then.
Rajesh, some comments which have come in. Rajesh, am I allowed? Yeah. Okay, so gait you have described. Some people were putting inputs about it being high stepping and also that we won't go into. Diaphragm, and this is C4, we stand corrected. When the diaphragm is involved, what should we look at? The respiratory rate or the single breath count? So I would say you look at both, but the single breath count is for monitoring improvement or worsening, because which will tell you how to progress with your therapy.
No, you look at the movement of the abdomen for diaphragm. When you take a deep breath, the diaphragm descends and the abdomen comes up. Here the child takes a breath, the chest is moving, the damn abdomen just doesn't come up. That tells you that the diaphragm is gone. Every time you take a breath, the abdomen must come up. And in a child who has intercostal weakness, then when he takes a breath, the stomach comes up, but the intestinal, the chest is not moving. That is difficult to appreciate just on examination. But diaphragm, and much more important, 80% breathing is contributed to by diaphragm.
So if diaphragm is gone, you are an impending emergency. Intercostals are gone, you have less impending an emergency.
Absolutely, sir. And what was the description of the gait? We called it as a cautious gait, and it was not high stepping, but she was putting her entire soul on the floor and walking, and she was taking small steps. We could not clearly say that it was a waddling gait, which we would have expected with proximal muscle weakness. I'm just answering a question here. I'm done.
Yeah, no. So a waddling gait would happen when there is only proximal muscle weakness.
Yes, right.
When there is proximal and distal, but more proximal, you will not get a waddling gait. So, for whoever has asked that.
You want his name?
I had a query, so if sir can enlighten us on this. In typical ascending paralysis of GBS, intercostals would already be gone by the time the diaphragm gets affected. So whether we'll get the classical signs of only diaphragm paralysis first, because that's why we check the chest expansion also and the abdominal diaphragm. Both should be.
I'll attempt, sir.
Sure. Sir is meant for both the sirs.
No. First I'll attempt and pass it on to him. But it is so quickly sort of progressive paralysis that the diaphragm and intercostals, there will not be that diaphragm has gone on Sunday and the intercostals will go on. It's so much of rapidly gone. So both may be affected more or less simultaneously. You may not be able to say that this has come up first. What you really want to know is which is affected more at that time.
What Dr. Khare said, 80% function from diaphragm, 20% from intercostals. So intercostals have a very little reserve. That is why what Tushar says comes out, that intercostals are seen to be paretic much earlier because the diaphragm still retains some percentage of function. That's why the point that he was making, I suppose, was that you see the intercostals getting paretic, the diaphragm still working, because imagine grade 1, 2, 3, 4, 5, you can't do that for diaphragm, but intercostals have a very little reserve. Little paralysis, that means they are just not moving. And then they subserve only on diaphragm. Okay, how does an SMA go? Same way again. Okay, so to that extent, clinically you see far more intercostals than diaphragm, but what is it? Both are involved. If they go down by 20%, imagine, the intercostal becomes 0, diaphragm 60%, still functioning. That's why the clinician sees intercostal easy.
So final diagnosis is
a quick word about would you give IVIG or not, or would you give methylprednisolone? Would you do plasmapheresis? What will you do and why? Or will you do nothing because it's going to be all right? So somebody takes it quickly so that we know that we exactly get to know what we do.
So in other words, when do you give IVIG is what sir is asking.
It's progressing.
So progressive means what? Can you elaborate on that?
Involving the respiratory muscle.
So you watch for next 2 weeks whether it progresses and then decide IVIG.
Non-ambulatory patient, we have to give IVIG.
Why not simply prednisolone? Okay, cheaper. Even though again same, no? IVIG is costly. 1 milligram a rupee. Okay, and 2 grams. Okay, 2,000 rupees per kilogram. Okay, and mostly bigger children. So 20 kilo child. Okay, so much of money. Why not oral prednisolone? So you need to argue that. Okay, IVIG is fine. Okay, 40,000 rupees as against maybe 40 rupees.
It will act fast compared to
this is acts fast. It will get better, no? I was told that even naturally it gets better. Where is the hurry?
In GBS, steroids have no much role. Like clinical trials say in GBS there is no much role of steroids.
Well, every other immunological disorder, nephrotic, rheumatic, every time steroid. What is this fellow different than the rest of the immune disorder? And when you have an anaphylaxis, Oh, again adrenaline and steroid. So why this?
So what I have read, they have said in clinical trials it is found that GBS
This is an acute onset antibody disorder. So you want to take away the circulating antibodies, not just suppress immune rate. That's why IVIG is superior to steroids. Okay.
So regarding IVIG and plasmapheresis, we will prefer the IVIG because it is less.
Plasmapheresis is first not available. It's very labor intensive. Okay. And in a bigger child, so much. So I think plasmapheresis I just brought out because yes, there is another modality. Absolutely right. IVIG is the only modality. Question is, being costly, in which patient you would say, let me wait. That is the question. Where can we wait in a... Theoretically, you need not wait at all. You should give IVIG every time. The point is that later the patient comes to you, more is the reason to be cautious and wait. Though theoretically the answer is even in second week, third week you give IVIG because it may halt the progression and may have a better outcome and prognosis. So that's the point. So today's philosophy is give IVIG anytime. Earlier it was thought that later you get, anyway you will get better. But you may not get better completely for whatever work. You give an IVIG straight up.
So there is a question. How have we ruled out transverse myelitis?
No.
Since it's a progressive disorder, we have no clear-cut sensory signs and no level and no bladder bowel no obvious bladder bowel involvement, at least not confirmed on examination.
Sometimes a small role for steroids, sometimes even after giving IVIG, the pain is tremendous. The child keeps on complaining of pain though the power is not deteriorating. And at that time a small dose of prednisolone given over a short time dramatically release the pain of the child, and therefore sometimes you may have to use for relief of pain.
And every time the IVIG doesn't work, sometimes you might have to repeat IVIG. Then if you are further not getting well, even a trial with methylprednisolone is worth it. And there will be occasional child who will linger on even on ventilation for a few weeks and still come out, having failed on improving on IVIG, methylprednisolone, etc. So I think we are not very sure on immune disorders whether that immunologically acting agent would definitely work or not. In GBS mostly it works, and that is what we say.
Sir, after how long do we repeat IVIG? When do we decide? How do we decide that?
When do you repeat IVIG in Kawasaki, for example? That means you expect first the progression to be halted. You don't expect an improvement. But after an IVIG, you still find the progression on, that means the IVIG is failed. Okay, that's the way you decide that. I just wanted to bring a point that it's not always that IVIG works. In fact, no immunological disease always works under our expected way. And there is a possibility of moving on further to do something much better. Yeah.
And for relief of pain, you don't have to give IVIG. Even a simple prednisolone is orally is good enough. Yeah.
So we stop the case now.
So one question.
Yeah.
Sir,
you will be charged for that.
Okay, sir. Thank you. For IVIG, what we give to the patients, it stops the progression of the disease. So in this child, the child was given maybe she had power 2/5 or 1, maybe 2/5 2 days prior. Now she has improved so rapidly. Like, does improvement come so fast in GBS? Like within 2 days, the child can sit from not able to sit to like standing and walking. Does the
this is a good sign. No? Why are you upset about it, as Tushar is asking? It happens.
Suppose you pass exam without much studying. What's the problem? Yeah. Okay. The point is, yes. What you are trying to say is that we did not expect. If your mother had asked, how long will it take? He said, no, it might take a long time. Okay. And here you are. Yeah. So the point is that quick recovery is not against our diagnosis because all immunological disorders behave very, very differently. One of them quickly comes out, another as expected, the third lingers on. This is the way science knows only that it's immune. And what is immune? The type of behavior of an immune system. Can a behavior of a human being be guaranteed? No. So behavior of a human system cannot be guaranteed. But average, all of us will behave averagely right. But you never know. So I suppose that's the answer. Yeah.
Thank you. So we conclude this clinic today. Rajesh, you were going to say something? No. So we conclude today's clinic with the announcement that the next broadcast will be on 29th of August, Friday that is, 4:30 p.m. from Lady Harding Medical College, New Delhi. And probably we meet the Thursday after that. Thank you so much for logging on.